Welcome, everyone. Thanks for sharing your evening with me. Now that we have the good weather, I'm sure you'd rather go for a nice walk when it's not so cold. And thanks for all surviving our snowy snowstorms. So this is a brand new talk from our Burnaby Division of Family Practice, our Empowering Patients program that Leona and I have been running for about 8 years and doing it online since the start of the pandemic. Hopefully doing some in-person talks again as things become safer. And today we're going to talk about lung disease. But I'd like to introduce Leona to thank her for all she does to make this program possible. And she'd like to highlight some resources available through the division in our primary care network.
Hi, everyone. Thank you so much for joining us tonight. So I'm just going to pop a few links into the chat for you that hopefully you'll find useful. And if you do, then you can share them with your friends. They're just services and resources developed by the Burnaby Division and our Burnaby PCN. The first link is going to be our Empowering Patients page, which highlights the schedule of upcoming talks and events, as well as recordings of past events that we've done over the past year. So if you've missed any one of our talks and you find one of the topics interesting, check them out. You'll see Dr. Wong and I live on video. And some of the topics that we've covered are diabetes, the patient-doctor relationship, healthy eating, emotional well-being, and many more. So please check that out. The second link is going to be our Empowering Patients resource page, and that has the presentations that Dr. Wong, as you're going to see tonight, and also a key points document. So he's basically pulled out all the top bits, and so you can print that off, download it, and again share it with your friends. The third link is for our Burnaby Primary Care Networks, or PCN, which is all the collaborative work that's been happening over the past 3 or 4 years in Burnaby with the Health Authority, the Burnaby Division, and other community partners. So there's so much going on, so many resources available for seniors, youth, our doctors, our nurse practitioners, and so be sure to check that page out. We do have another, under the PCN, another health talk program called Doc Talks, and we have other doctors come in and speak about interesting topics such as, I've noted some here, blood pressure, COVID-19 boosters, if you're still having questions about that, and the importance of foot care for your health and well-being. So there's no Doc Talk scheduled at this time, but you can actually see recordings of ones that we've done in the past. If you're looking for a family doctor in Burnaby, yes, there is a wait, but I'm going to pop the page for the patient attachment initiative into the chat, and you can read up on what the program's all about and add yourself to the wait list. So if you live in Burnaby and don't have a doctor in Burnaby, then by all means get yourself on that list. And lastly, some of you might be familiar with the COVID Roundup newsletter. We were sending that out weekly, just giving you all the highlights of what was going on COVID, vetted resources. And what we've done in February is we've transitioned that away from all COVID all the time to a more holistic wellness, what's going on in public health, some COVID where it's applicable. And so we're sending that out monthly. So I'm going to pop a link to the February issue into the chat. You can have a read. And if you sign up tonight, then you will receive the March issue, which is going out tomorrow. And lastly, at the end of our talk, when I close down the webinar, there's going to be an 8-question just evaluation. And if you wouldn't mind filling that out, that's really helpful for Dr. Wong and I. We really value the input, and it helps us sort of form the program as we go. And that's it. We've got Walk With Your Doc coming up soon, so I'm going to let Dr. Wong talk to you about that. So that's it from me. I'm going to pass you back to Dr. Wong.
Thank you, Leona. And thanks for all the good work you're doing on behalf of the Burnaby Division of Family Practice.
Thank you. It's my
thank you. The Walk With Your Doc is, Leona, do you have the date for the Walk With Your Doc?
Yes, it's Saturday, May 6th. Registration's at 9:30 in the morning at Confederation Park. So come out and join us. Dr. Wong will be there. Bring your dog, bring the family.
Yeah, and there'll be a bunch of family docs and other doctors from the Burnaby community showing that we value physical activity, but we really value our community. And we're not only talking the talk, we're walking the walk and walking with our patients in the community. So it's a great time to meet you in person in a safe environment and traditionally the mayor always comes. Yeah, Mayor Hurley has been a great supporter of the Walk with Your Doc in the health of our community. So this talk is what you should know about lung disease. When I have these talks like what you should know about heart disease, what you should know about medical ethics, it's not that I'm making a judgment that you should know this, but it's something that as a family doctor, these are things that I wish my patients knew. And I wish I had the time to explain all these details to them. So it's a real luxury to be able to share it in this way. And a lot of people that do have these chronic conditions don't know some of the basics of how things work because no one puts it back into plain language. So that's kind of my goal. And I appreciate your feedback. So filling out the questionnaires at the end, because this is a brand new talk. I was just telling Leona, I spent 6 hours preparing for this talk. That's only an hour and a half long. So welcome your feedback and your questions at the end as well. And if questions come up, just put them in the chat. I can't see it, but Leona will read the questions to me at the end. So as part of our Empowering Patients Health Program, which is obviously nonprofit, we're not trying to sell you anything, unlike where you get a lot of information on the internet, on the news, on the radio, on television, where people are trying to sell you some biased information and biased products. So we're here because we really care about you. And again, Leona said there's the links on the Burnaby Division webpage, so you can get information about upcoming talks and the resources from this talk, including these slides, and all the slides and videos from recent talks as well. This talk is dedicated to my dad. It's his birthday today. He just turned 93, and he's my model for mental, physical, emotional wellness. So as we say in healthcare, we were made to move. When we don't, our health suffers, but when we do, we thrive, like my dad. So why are we here? I think we're all here as a part of a circle of caring. As family doctors, I really care about my patients. And I have a rule of, my family practice rule is we treat every patient like we want a family member or best friend to be treated, the same care and consideration. But as a family doc, I care about my community as well. That's why I'm giving back to the Burnaby community that I grew up in, where I went to school, had swim lessons, and went to the public libraries. My favorite one was McGill growing up, close to where we're doing the Walk with Your Doc, the Walk with Your Doc. And we care about the future, because as your family doctors get older, we want to make sure new family doctors come in, but we know that it's a bigger circle of caring. So if I can share some valuable information that's really resonates with you, I'm sure you can share some things that you learn with loved ones and colleagues and friends and neighbors who would also benefit. So we care about our patients and we care about our community. This is from one of our previous walks with your doc. So today I'm going to talk about the basic anatomy of the respiratory system, not just the lungs. I'll explain how the lungs work. So it's just not like balloons in each side of your chest that expand and contract. I'll talk a little bit why we need oxygen and how it gets into our body and how it circulates. We'll talk about the symptoms of respiratory disease that should alert you to perhaps talk to your doctor to look further. The symptoms of pneumonia and bronchitis and what's the difference. We'll talk about one type of lung disease that you may not have heard of, but is fairly common, interstitial lung disease. And of course, asthma and chronic bronchitis and emphysema. And I'll tell you a bit about sleep apnea and how you can screen yourself to see if you might need to see your doctor to get tested for problems with breathing at nighttime. We'll talk about lung cancer and how to screen for it, and some rare conditions that are quite serious, pulmonary embolism and pneumothorax. So covering a lot of ground, but I promise to explain it in easy to understand terms. And I always start our talks just reminding that healthcare is not just what happens in the hospital, like in Grey's Anatomy, but a lot of it happens in the community. The majority of it does. But the person that provides most of your healthcare is not your family doctor, it's you. And real healthcare, in our view, is self-care. So you provide the most important healthcare, but it's our job to support you, giving the knowledge and resources and connections so we can help you be at your best. And the best predictor of your future health, of the things that we can control, are the habits we practice every day. what I call the 4 foundations of self-care. What you put into your body. So what you eat, including healthy things and also unhealthy things like too much alcohol or cigarettes or recreational drugs. Second foundation is what you do, physical activity balanced by rest. The third foundation, how you feel, emotional well-being. And then finally, how we connect, healthy relationships, 4 foundations of a healthy life. What you eat, what you do, how you feel, and how you relate. And these were all topics of our recent talks that we repeat and revise regularly, but you can find the past talks on our website. And a reminder, my next talk is on April 13th, so just a month from now, on what you should know about medical ethics. And again, all the resources beyond the Empowering Patients, that all the activities the Burnaby Division is doing, a nonprofit association of family doctors that serve the Burnaby community and connected to all the others that support health and wellness in Burnaby. So for good self-care, you need objective knowledge, you need professionals to support you, and colleagues, neighbors, and friends. We need planned proactive care. And health is not the absence of disease, and healthcare is certainly not just the treatment of disease. In fact, family practice, I think, is different from every other specialty because we don't treat disease, we treat the patient. We only see disease in the context of that person's life, and we want to help them achieve their positive potential. Because I personally believe that each of us has a unique potential in this life, and it's our duty to realize that potential. That's your gift to the world, and to help others achieve their positive potential. And the positive potential doesn't have to be perfect, because none of us is. It's guided by your personal values. So knowledge, support from us, and planned care. So let's start with the respiratory system. So you've probably seen lots of diagrams, but I want to show you a live specimen that I dissected this morning. So this is a recent shot. So you probably never saw lungs like that, because it's actually the orange that I was eating for breakfast. But lungs are really delicate tissues. They're not just bags of balloon, and they're probably more delicate than the oranges, and they're protected within our chest. That's why we have our ribs to protect our lungs. Our chest can expand because of those ribs, the way they articulate, and they help draw air into our lungs, which are very delicate tissues. And they could be easily damaged by toxins that we can inhale, including cigarette smoke and pollution as well. So the respiratory tract consists of the upper and lower respiratory tract. And we know that all the lining or the mucosa throughout the upper and lower respiratory tract has a receptor for which the SARS-CoV-19 spike protein likes to attach. That's why we had this trouble with COVID over the past 3 years, because we have lots of respiratory mucosa and the upper respiratory tract is very accessible. So the upper tract consists of your nasal passages and the back of your throat, which we call the pharynx, descends down into the larynx, where your voice box is in the front, down the trachea, a tube in the middle, which branches into the bronchi and into the lungs. And your lungs are made of 2 lobes, just like those 2 lobes of the orange I showed you. So we call it the right lung and the left lung. And we actually divide each lobe of the lung, each side of the chest, the lungs, into separate lobes. So the right lung on this side of your chest is a bit larger than the left side, because the left side makes room for the heart. You can see the outline of the heart on the right side of the picture, but that's the left side of the chest. So the right lung has the upper, middle, and lower lobe. And when I'm listening to a patient's lungs with a stethoscope, usually with the diaphragm part, the flat part, when I'm listening up here, I'm listening to the upper lobe. The middle lobe is a little strip around the ribs. And most of the lower lobe, we listen to the back of your chest, just because it's kind of positioned that way. And when we're listening to the left side, the upper lobe is most of what we're listening to in the front, and the lower lobe is most of what we're listening to the back. So that's why we don't simply listen up to just the top of your chest, that we want to listen all the way around, so we have a clear understanding what's going on in the lungs. And when I'm listening for are for sounds such as a wheeze, a musical sound when you're breathing out. I'm listening for crackles that we might hear if there's some fluid in your lungs, or if there's pneumonia, it has a little fine crepitations that we hear as well. I listen for areas where there's decreased entry of air, because that could be fluid in the lungs, or what you'll find out later, pneumothorax, or air that's escaped and pushing the lung to the side. So the way the lungs work is that air goes down your trachea. So that's the big central tube, your breathing tube. And then down the trachea, it branches into the right and left main bronchus, so the big airways. And the left bronchus empties air into the left side of the lung, and the right bronchus to the right side of the lung. And it's just like a tree, the branches of a tree or on a leaf. So the main bronchi branch into smaller little passages called bronchioles. And then the air passes gradually into smaller and smaller bronchioles into the alveoli. So they're very, very tiny, and there's many, many within your lung. So in the diagram, it's that little bubbly thing that you see on the right. So the alveoluses are really surrounded by very fine membranes with very fine blood vessels. And it's here that air within the alveoli can pass gases into the blood vessels that are surrounding the outside of the alveoli. So that's how your blood gets rich in oxygen and empties the carbon dioxide that you want to exhale. So that's why the lungs are so delicate on the inside and so well protected by our chest wall or the ribs. And the two main arteries that supply blood to the lungs are the pulmonary arteries and the pulmonary veins. So the pulmonary artery receives the blood from the right side of the heart. So that's blood that returns through the inferior vena cava from all the organs in the body, and the superior vena cava from the head and the other areas above. That brings the blood oxygen's been taken away by the tissues already. So the pulmonary artery brings that blood into the lungs, circulates into the smaller blood vessels, and in the alveoli, where the air is exchanged, oxygen goes back into the blood vessels from the alveoli, and through the pulmonary veins, that oxygenated blood, oxygen-rich blood, goes back to the left side of the heart, where it's pumped to the rest of the body. So that gives us a constant supply of oxygen, which you need. It's actually hemoglobin in the blood that binds to oxygen. And that's why if we're anemic or low in hemoglobin or iron, that we feel tired and exhausted, and our muscles don't work so well, and our brains don't work so well if we become anemic, because less oxygen travels because there's less hemoglobin. How exactly do you breathe? I did talk about that the ribs expand to increase the chest wall to bring air into the lungs, and most people think that when they take a big breath, it means making your chest really big, like Captain America or Superman. But the most important muscle for you to breathe with is the diaphragm. So the diaphragm is a domed muscle that divides the chest, what we call the thorax, from the abdomen below. So the diaphragm just sits at the top of the abdomen, at the base of the lungs. And when the diaphragm contracts, it goes from a dome and it flattens out. And when it flattens out, when it contracts, your abdomen comes up. That's what we mean by belly breathing. So when you breathe in, the abdomen comes out because the diaphragm descends and contracts, and it draws air into the lungs, down your nose and mouth, into the trachea, into the bronchi, the bronchioles, and into those little alveoli where the oxygen can pass into the red blood cells and supply your body with energy, including your brain. So remember, when you want to get a good breath, when you're going for a walk, when you're trying to relax, you get a bigger breath if you belly breathe. So that's when you breathe out, your abdomen goes in, and when you breathe in, your abdomen comes out, pulling the diaphragm down. And when you exhale, when that diaphragm relaxes, your belly comes in and the air passes through your throat. And then if you decide to, you can say something. That's actually how we speak. The vocal cords change in shape and contract, and that changes the sound. So that's how we sing and that's how we talk. through breathing, through exhalation. So I'll just go through some common respiratory symptoms, and then we'll kind of get into the different types of conditions that can affect the lungs. So the common question that a doctor will ask you, if you happen to have a complete physical like we used to do in the olden days, just a reminder, there are no routine physicals that are covered by medical services plan, but physicals, if they're justified due to systemic symptoms or unexplained weight loss, it can be justified. So if you're not sure if you should have a physical, talk to a healthcare provider. But when we're talking about the respiratory symptoms, we often ask, do you have difficulty breathing? This could be a symptom of asthma, chronic lung disease, anemia, heart disease, heart failure, lung cancer, or COVID. And do you wheeze? So that's the musical sound when you breathe out, assuming your mouth is not attached to a clarinet or a flute. So this could be a sign of asthma or bronchitis. And essentially a wheeze is a noise caused by a narrowing of the airway or a partial blockage of an airway. So the airway is narrowed, so it creates a sound. So if someone were to have a growth or a tumor in a bronchi or a bronchiole, it will also produce a musical sound. So the wheeze is not necessarily a sign of bronchitis infection or asthma, but we'd also want to make sure that it's not due to a cancer or growth in the lung. And have you been coughing? So some people have chronic coughs due to allergies, some temporarily cough due to colds. It could be caused by postnasal drip, typically when you're lying down, or it could be due to bronchitis, acute or chronic. Asthma, acid reflux can irritate the throat and cause a cough. Of course, COVID, pneumonia, and respiratory tract cancers. And have you coughed blood? So if you cough up blood, it could be something simple like a nosebleed, like when you have a bad cold. It could be from a broken blood vessel from vomiting or coughing really hard. But it could also be due to cancers in the nasal passages, the nasopharyngeal area in the back of the throat, or it could be due to lung cancers. So when you report this symptom, then we want to have a good idea what it is, but also rule out the most serious things, particularly as we get older. So this is kind of a basic classification of common types of lung disease that we'll be talking about. So there's airway disease, like chronic lung disease, chronic bronchitis and emphysema, asthma, bronchitis, pneumonia, or COVID. There's diseases of the lung tissue, including fibrosis of the lungs, or interstitial lung disease, and connective tissue conditions like sarcoidosis. There's a problem with the circulation, like higher blood pressure in the pulmonary blood vessels, and pulmonary embolism, which would be a blood clot in the circulation within the lungs. And then finally, lung cancer. So we'll talk a bit about each of these conditions. So bronchitis and pneumonia, acute bronchitis and pneumonia are acute respiratory conditions. Acute means short-term. And these are considered lower respiratory tract infections as opposed to upper respiratory, which is more sinuses, nose, ears. So acute bronchitis is an infection mainly causing inflammation in those bigger airways. Remember, the trachea branches into the right and left bronchus, and then the bronchioles. So bronchitis is inflammation, usually due to infection of those main bronchi. So the symptoms are similar to pneumonia. It could be a deep cough in your chest, obviously shortness of breath, particularly with exercise. It could be feeling of chest congestion. Sometimes it's productive of mucus, and some of the mucus could be darker or lighter colored, and sometimes associated with musical sounds or wheezing. So it's usually a diagnosis based on the doctor listening to your lungs. Sometimes we can see it on an X-ray where we see signs of inflammation in the bronchi, but it's not usually reported on the X-rays by the radiologists in the community. Different from this is pneumonia, which is an infection in the deeper tissues of the lungs, like where the alveoli are. So that's really in the substance, the spongy substance of the lungs. So again, you have cough, shortness of breath, worse with exertion, like walking up the stairs or doing laundry. Your chest will be more congested with chronic bronchitis. It's sometimes productive of mucus, and sometimes there's wheezing, and sometimes there's chest pain with breathing as well. And we generally can get a good idea if someone has pneumonia, not just with these symptoms, but again, listening, what we call auscultating with the stethoscope. And again, as I mentioned, we listen to all the 3 lobes of the right lung and all of the 2 lobes in the left lung. So listening very carefully, because pneumonia could be in any of those areas. And if we don't listen to all these lobes, we may miss an area where there's some crackling or decreased air entry. Sometimes we'll percuss. That means putting our finger on the patient's back or chest and then tapping. So percussion can tell us where there's normal aerated lung, and it tells us where there could be fluid in the lung or a pocket of pneumonia as well. So one of the clinical skills that gradually gets lost if we do too many virtual video type visits. You cannot diagnose pneumonia with a phone call or a video call either. Pleurisy or pleuritis is inflammation of the outer lining of the lungs. So the pleura are these fine membranes that surround the outer surface of the lungs. And they're often associated with pain, breathing in and breathing out as the lungs expand. So sometimes a pneumonia is associated with pleuritis or pleurisy as well. So asthma is different. So asthma is a chronic condition. It's usually hereditary. So other family members may have allergic rhinitis like hay fever, or eczema, chronically itchy skin that responds to anti-inflammatory creams like steroids. And other family members may have asthma. So that's kind of what we call an atopic or an allergic type family history. So it's often allergic, but not always. And asthma is defined as reversible airway constriction, what we call bronchospasm, so intermittent wheezing. And it could be triggered by cold air or things in the environment that we're allergic to. And people with asthma, when they get a regular cold, will tend to cough longer and more deeply and be more short of breath with those respiratory infections than people that don't have asthma. So the symptoms can be, of course, coughing, wheezing that sometimes if severe, the individual or people next to them can hear it as well. Again, that's a musical sound when you're breathing out. And that's different from stridor, which is a musical sound when you're breathing in. So a wheeze is a sound when there's more lower respiratory tract development, and stridor generally involves narrowing of the upper areas, like in the trachea. Common in little kids with croup, where the airways can narrow a bit with a respiratory infection, and they produce a sound when they're breathing in. Commonly with asthma, you'll have increased shortness of breath or wheezing with exercise, with exertion. And it can, as I mentioned, be triggered by cold air, with exercise, and with allergies. And asthma often is worse at nighttime, just because their immune system kind of goes into overdrive at some different periods of the day. So asthma often worsens at night. And we diagnose asthma ideally with pulmonary function tests. That means lung function tests. And they're generally done in the hospital. We used to have this type of equipment in the office, but it's quite cumbersome and time-consuming, and is ideally done by a respirologist. So they're very specialized respiratory technicians that can ensure that coach the patient to put 100% effort into blowing really hard through this tube. And then it measures different areas that tell us the lung capacity, the lung volumes, and how quickly and forcefully we can exhale. So with asthma, we get reversible airway constriction. So we have narrowing of the airways when we force the air out, but it can be reversed with a bronchodilator or an inhaler. So we do spirometry or pulmonary function tests to diagnose chronic lung disease and asthma. And to confirm asthma, we do something called a methacholine challenge test. Methacholine causes bronchoconstriction. So people with asthma that are prone to that will see a difference when they take the methacholine versus when they use Ventolin that opens the airways. A little picture on the left with the little boy in the yellow shirt, he's blowing through a peak flow meter. So that's an office device we sometimes use just to check to see how severe someone's asthma is at that time. Because normally when we blow through that tube really fast, there's a number like 500 liters per minute that we're able to forcefully blow out. And it's a different amount depending on your age and how tall you are. And we can find out what someone's baseline is. And when someone has asthma, we can actually use those peak flow meters to see if they have a bad asthma attack and kind of direct them about what kind of medications they might need to use. We treat asthma with a number of inhalers. So usually the first line is a short-acting puffer. You've probably seen it before, the little blue inhalers that kids might use in school. A common name is salbutamol or Ventolin. So that quickly opens the airways. It's called a bronchodilator because it opens up bronchi. And that alleviates the wheezing or the tightness in the chest. And that's good for just the acute symptoms of asthma, so you can keep on running during your marathon or your morning run or cycle. But if someone is using that frequently, we usually recommend something to decrease the inflammation of the lungs. So a second line would be inhaled steroids. Examples are Flovent or Pulmicort. So they go into the lungs, they don't immediately give relief, but they decrease inflammation. Because if we had someone with quite severe asthma and they only use the short-acting bronchodilators, over time their airways change and they get some permanent changes in their lungs, similar to chronic lung disease. So this inhaled steroids are really important for decreasing that inflammation so that the lungs maintain their health and elasticity. There are long-acting bronchodilators, and they're usually combined with the inhaled steroids so that they last longer through the day to keep the airways open, the day and the night, and they have that steroid that decreases the inflammation. And less commonly used would be oral medications. And there's a particular antihistamine called Singulair that's prescribed for certain people with asthma, particularly allergic asthma. That's quite effective for adults and children. And then for really severe asthma that's not responding to inhalers, sometimes we'll prescribe a short course of prednisone tablets. Taking oral steroids does carry a number of risks that the doctor would explain to the patient, but it's sometimes used just to give some immediate relief for the short term for severe attacks of asthma. So we have these quick acting bronchodilators, we call those the relievers, and we have the preventers, which are the inhaled steroids, sometimes combined with long-acting bronchodilators. So it's important if you do have asthma or your child has asthma, that you're familiar with these two types of puffers and have what we call an action plan, so that with your prescribing physician, you know when to use the inhalers, when to use a short-acting one, perhaps just during a cold if your asthma is really mild. But if you have a flare-up of asthma or more chronic asthma symptoms, don't rely on just the blue inhaler. You want to use an orange or brown one that can decrease the inflammation and decrease your need for the short-acting bronchodilator. And there's a variety of devices that are used. So typically we say inhaler, we mean these, we call metered dose inhalers. So they're on the second line, kind of L-shaped, where you have to time it, push down when you're breathing in. So it takes a bit of practice to do. And a lot of that, the spraying ends up in the air or in your eyes as well. So they're best used with something called a spacer. It's like a toilet paper roll that's connected at the end of the inhaler so that you can take your time and inhale all the medication into your lungs with a spacing device. There's discus inhalers, those are the round things on the top where you just suck it into through your lips, into your trachea, into your lungs. And there's the turbuhalers that you see as well on the third line. So you also suck those in through your mouth into your lungs. So chronic obstructive lung disease, or COPD, or chronic obstructive lung disease, COLD. So this includes the conditions called chronic bronchitis and emphysema. So similar to asthma, there's narrowing of the big airways, the bronchioles and the bronchi. So we call it bronchoconstriction, and there's inflammation of the airways as well. In many cases of chronic lung disease, it's caused by exposure to toxins in the air. Number one is tobacco in cigarettes. We don't know all the chemicals that are in cannabis that they're smoking, and we don't know if they contribute to chronic bronchitis or emphysema. And we don't know what other things are in vapes that young people like to inhale now, also for recreational drug delivery. So they need to keep in mind that the risks are not known and all the ingredients are not known, depending on where you're obtaining these devices. But in the case of chronic lung disease, it's irreversible bronchoconstriction. So it gets worse over time, the longer we get exposed to the noxious chemicals that have caused it. And the airways lose their elasticity, they become more rigid. And that's why it's less reversible and usually irreversible. You can't really diagnose chronic bronchitis or emphysema. It's more of a pathological diagnosis. We see signs on chest x-rays, because there's some typical findings on the x-ray, like little bullae, almost like blisters in the lungs, in the upper lobes on the chest x-ray in people with emphysema. In general, people with chronic lung disease, because they have difficulty exhaling because of the bronchospasm, their lungs are typically overinflated and the diaphragms are flattened out most of the time, even at rest. So on the x-ray, it looks like someone's taken a super duper deep breath. We were taught in medical school that someone with chronic bronchitis generally is a little bit more cyanotic. They're often a bit more overweight. We call them the blue bloaters. And they tend to have more of the sounds of wheezing when you're listening to the lungs. People with emphysema tend to be older patients. They tend to be thinner. They tend to be like very short of breath, but they're not necessarily wheezy. So this is one of those x-rays. You see that the diaphragm on the right side, they're flattened out instead of nice and round. And common causes could be cigarette smoking and also exposure to pollution over time. So another reason to be wary of our climate and to not drive gasoline-powered vehicles if we can help it. The symptoms of chronic lung disease include a chronic cough that doesn't disappear and often gets worse when we have chest infections like colds or COVID or pneumonia or bronchitis. Often there's an increased production of mucus, generally in the morning, and shortness of breath on exertion, like climbing up the stairs or walking uphill. That could be shortness of breath even when you're at rest, and that's in severe cases. And as I mentioned, it gets a lot worse with respiratory infections. That's why everyone with chronic lung disease should obviously get a COVID shot, but importantly, getting their flu shots. And as I mentioned later, the pneumonia shot. And then, as I mentioned, sometimes there's some chronic wheezing or musical sounds when they're breathing out. And again, both these conditions are diagnosed definitively and also monitored with pulmonary function tests, the breathing tests that are done at our hospitals. So how do you treat chronic lung disease? Well, number one is to stop smoking if you are smoking. And there's some great resources in BC. So if you or a loved one are ready to quit smoking or even contemplating it, check out quitnow.ca. So that's the provincial program for support for quitting smoking. And BC happens to have a smoking cessation program. And if you're ready to quit smoking, one way is through nicotine replacement, because the addictive part of smoking is mainly the nicotine that gives an individual a sense of well-being, and that's the most addictive part of the smoking. But the noxious part of the cigarette is all the toxins that you're inhaling, and that causes the damage to the lungs and also contributes to the risk for lung cancer. with the smoking cessation program in BC, if you register, you could simply go to the pharmacist and they can give you a supply of nicotine replacement gum or lozenges or inhalers. So that's available, and all you need to do is show your care card and explain that you're trying to quit smoking. So a pharmacist can sign you up and give you free samples. I think you're allowed up to 12 weeks. They might give you a month at a time to help you along to quit smoking. And as I mentioned, there's a variety of inhalers, even more than we have for asthma, to decrease the inflammation of the lungs and to open up the airways where we can. Unfortunately, most people with chronic lung disease don't have as much response to the short-acting bronchodilators. That's why we have a variety of other agents to use. And people with chronic lung disease should ask their doctor about respiratory rehabilitation. So it's peer support and experts like respirologists and nurses that can assist you in things you can do every day to improve your function in spite of having chronic lung disease. In severe cases, individuals with chronic lung disease decline such that they need to have home oxygen, and you see people that are carrying little oxygen tanks with them if they're leaving the house, and they often have them at home or need it when they're going to sleep at nighttime as well. So not everyone, of course, we all feel good if we have extra oxygen, but not everyone is allowed to actually have a home oxygen because there's some safety guidelines as well with oxygen. It's highly flammable, of course, but it can be provided depending on your oxygen levels. So usually a respiratory technician will measure your oxygen levels when you're exercising, when you're at rest, at sleep, to determine if you meet the criteria to be low enough that you require home oxygen. So here's the bewildering array of inhalers, including inhaled steroids, long-acting bronchodilators, short-acting bronchodilators, muscarinic antagonists, anticholinergic medications, and there's a variety of combinations of all these modalities in different inhaler type devices. So if you use these types of inhalers, it's good to sit down so you have with your doctor to go over what the inhaler is supposed to do and how to use them. And again, we don't really want to rely on short-acting agents because we're ignoring the chronic condition as well. Now, individuals that have increased risk for respiratory infections or an increased risk for a serious infection with strep pneumonia, which is only one strain of Streptococcus, qualify for a vaccination, what we call the Pneumovax. So in BC, everyone over 65 actually qualifies to get Pneumo 23 or the Pneumovax. So that's free through public health, and most family doctors' offices carry it as well. So if you're over 65, ask your doctor if you should get a pneumonia shot. Individuals, regardless of age, who live in residential care or assisted living facilities are at increased risk just because of the close quarters and the other people that they're living with to suffer from strep pneumonia or have serious consequences if they get strep. This does not prevent all pneumonias. Pneumonias can be caused by viruses and a large number of bacteria, obviously from COVID-19 as well, another virus. So, but this is only against strep pneumonia, and each of these vaccines covers only specific strains. Others who have certain chronic conditions, including chronic lung disease or asthma that's bad enough that requires medical care, usually qualify to get the vaccine free as well. And there's a number of other conditions such as diabetes or coronary artery disease, and other conditions where people are at higher risk, but they also qualify. You'll see advertised Prevnar, originally Prevnar 13 and Prevnar 20. So you'll see those advertised on television, recommending it for everyone over 50. But in Canada, Canada Health doesn't recommend it for everybody over 50. For now, most people over 65 and people with certain chronic conditions who are at increased risk. So that if you get those extra vaccines, they're not covered by public health yet in BC, They are in some jurisdictions, like in the States, depending on people's plans. The Prevnar 20 is the latest one, and that covers strains that are not necessarily covered in the standard Pneumovax. So it's something that could be added on. But talk to your doctor if you qualify for the Pneumovax, and if you do qualify for the Pneumovax, whether you should consider those privately paid vaccines, Prevnar 13 and Prevnar 20. So lung cancer. So this X-ray shows that where the arrow is pointing is something that could miss the untrained eye, but a radiologist can detect whether that could possibly be an area of lung cancer. So lung cancer can either be primarily from the cells of the lung, what we call primary bronchogenic carcinoma, or it could have spread from another part of the body, which is more common. That's metastatic lung cancer. So a colon cancer can metastasize or spread from the colon, the large bowel, to the lung. So, and obviously they're treated in different ways. The symptoms can often be no symptoms at all, and we might catch it incidentally by the appearance of the chest X-rays. So just in the past week, I've had 2 patients, and their X-rays definitely looked abnormal and highly suspicious for possibly having lung cancer. So our next step is to do a CT scan as soon as possible, because that will give us more detail. So sometimes people have no symptoms at all. Sometimes it's the chronic cough, which could be many other things. But generally, if you don't have asthma or chronic conditions that you know of, and you've had a cough for more than 2 months or 3 months, or if it's getting worse, definitely see your doctor so they can listen to your lungs. They would probably at least order a chest X-ray with a chronic cough, unless it's obviously that it's due to allergies that we can easily treat and take care of. Increasing shortness of breath, unexplained weight loss, or coughing up blood. Sometimes wheezing could be a symptom. So not many people have all those symptoms, but any one of them, if you explain them to a family doctor, then they would want to rule out lung cancer, particularly as we get older, or if we smoke. In BC, we've just started the lung cancer screening program. And it's a free program, and it uses a low dose of radiation. It's called low dose CT. So a lower dose than we usually use, so it doesn't increase your risk for cancer. So you would qualify if you're between 55 and 74, have a history of smoking, have a healthcare provider to whom they can send a report, so that we definitely would get follow-up and do further investigation if a test indicates possible lung cancer. And of course, be willing to go for the CT scan, which is a fairly quick test to do procedurally. And what you see at the bottom one is just kind of a questionnaire that determines what your risk is. So if your risk is greater than 1.5% over 6 years, then you would also qualify. So these are the inclusion criteria. So to learn more about it, you don't have to get a referral through your family doctor, but you'd probably want to identify your family doctor if you signed up for the program. So you can call this number listed below, or you could check the website at BC Cancer Society or BC Cancer Agency, bccancer.bc.ca, screening lung, get screened. So this isn't really a lung disease, but it is a respiratory condition that's exceedingly common. So you've probably seen sometimes at the airport, you see people carrying their CPAP machines when they go on holidays, or see people carrying them onto the cruise ships when they're going there for a 1 or 2 week holiday. So it's a very common condition, but often undiagnosed. So obstructive sleep apnea is a common condition where, as we get older, usually, the soft tissues in our throat, which are supported by muscles, tend to fall back into the back of the pharynx, the nasal pharynx, where air passes in when we're sleeping. And it blocks the flow of air into your trachea, so you're getting lower amounts of oxygen circulating throughout your body because the airway is partially or completely obstructed for many periods throughout the night. So The common symptoms are daytime drowsiness, loud snoring, often with choking or gasping during the night. So most people don't know if they snore. It's only if they happen to be sleeping with someone else that they'll notice. And it's only if that other person is awake in the middle of the night at the times that you snore. Sometimes people have a headache in the morning. That can last for a couple of hours. And sometimes people report really restless sleep where they wake up partially throughout the night and they don't know why. But the key symptom is nodding off during the day, being able to take a nap at any time something is boring or you're not stimulated, like watching a TV show in the middle of the day or after lunch in a quiet room, or if you just happen to lie down, you fall asleep instantly during the day. Or if you're a passenger in a bus or in a car and you can nod off in a couple of minutes, you're either sleep deprived or it's possible you could have sleep apnea. So sleep apnea is pretty serious because most people that are impaired, just like someone that's had a few too many drinks, doesn't recognize that they are impaired. You know that if you ever had a friend that drank too much and trying to get the keys away from him so he doesn't get in the car, they will resist because they don't think they're impaired at all, but it's obvious to everyone around them. So this has resulted in many accidents. So it's really important to recognize if you have any of these symptoms. It can cause cognitive impairment. And again, most of us don't know how impaired we are unless we're writing an examination. It contributes to increased blood pressure. So sometimes it's the cause of high blood pressure. And of course, marital discord because of the loud snoring. So it can be diagnosed in two ways. If someone's at mild or moderate risk, depending on their risk factors, then we do the home sleep apnea testing called HSAT. So this is done at many of these community respiratory clinics that have popped up because they want to sell you their CPAP machines. So they're willing to do those tests for free. And it involves wearing a device overnight and it measures your oxygen levels. And some of them have very sophisticated devices that can tell how many hours you're sleeping, how many hours you're sleeping on your side or sleeping on your back. And most importantly, it measures your oxygen level and it can calculate how many times per hour you stop breathing. So the average hypopneic index. If someone is at high risk for sleep apnea because they've had witnessed choking, stopping breathing, really loud snoring, falling asleep all the time during the daytime, and other risk factors, then they probably should go get what we call a polysomnogram. So it measures many more things, and that involves an overnight stay at the sleep lab, such as at UBC. But the simple tests from the sleep clinics in the community, the HSAT, can be done at home. So the standard treatments for sleep apnea would be weight loss if you're overweight, because that tends to reduce the extra tissue in this area that can fall backwards and block your airway. We should avoid alcohol or sedatives. That includes sleeping pills. So people that have trouble sleeping are always begging for sleeping pills, but those sleeping pills can actually give you really poor sleep. It doesn't give you the restful sleep, and it can make those muscles relax even more and reduce your brain signal to take a big breath. So sleeping pills actually increase your risk for dying and for accidents. So please try to resist acting for sleeping pills, but do talk to your doctor about your sleep because there's better, safer ways to help you have a good night's sleep. Alcohol is quite sedating, but of course it's stimulating as well and can disturb your sleep, but it can also contribute to that deep relaxation of your soft tissues, contributing to the sleep apnea. Sleeping on your side helps a lot. So one tip I have for people that can afford these expensive CPAP machines is to just put a tennis ball in your fanny bag and put that on the back of your chest or back so that you'd have to lie on your side to be comfortable at night. And then during the middle of the night when you're half asleep and roll onto your back, you'll wake up just enough so you'll roll back onto your side. And there's also oral appliances that push your lower jaw, the mandible forward, so that the tongue doesn't fall back into the back of your throat. So those are relatively inexpensive, and you can buy them online as well, but they don't work for everybody, and they don't work on severe cases. So here's an example of one of those appliances. So a Pure Sleep is one brand, but there's many, and they range in price from $20 to $40, and you can custom make it for your mouth. They don't last forever, and my dentist says that it can actually change how the teeth are lined up in the back of your mouth, because they won't reach all the teeth, the molars in the back of your mouth. So it can change the relative levels of your teeth. So long term, if you need this and it works for you, the doctor may give you a prescription to get a custom-made dental appliance. And some dentists have expertise in this area. Those devices are very expensive, but sometimes covered by extended medical as well. They're similar in price to the CPAP machines, like over $1,000. And here's an example of having something like a fanny bag and a tennis ball in the back, so that if you roll onto your back, you'll be rolling back onto your side, because sleep apnea is generally worse when you're sleeping on your back. And this is the idea with CPAP. So these are the machines people will purchase if they have moderate to severe sleep apnea. So these devices basically push air. So it's not oxygen, it's just room air. It's pushed through the nose passage to the back of the nasopharynx. So it opens up the airway down into the trachea. So CPAP stands for continuous positive airway pressure. But there's other devices that vary the amount of pressure. They might decrease the pressure when you're exhaling, so that it's easier for you to breathe out, and then increase the pressure when you're breathing in. So take a careful look at this questionnaire. This is called the Epworth Sleepiness Scale. So for each of these situations, you want to think of giving yourself a score. So a 0 so the question is, how likely are you to fall asleep if you're sitting and reading? So if you would never doze or fall asleep, that would be a 0. If there's a slight chance, a 1. If there's a moderate chance of dozing off, it'd be 2. And if there's a high chance you're going to fall asleep, it'd be 3. So 0, 1, 2, 3. So if you have a pen and paper, you can keep score for yourself. So sitting and reading, how likely is it for you to doze off? So that would be 0, 1, 2, or 3. 3 being a high chance, 1 being slight chance. And how likely are you to doze off if you're watching television or sitting inactive in a public place, like when your wife is shopping and you're just sitting waiting for her to finish in that next store? Or if you're in a movie theater or at a boring meeting, how likely are you to nod off? And then how likely are you to fall asleep or doze off if you're a passenger in a car for an hour without taking a break? Or lying down to rest in the afternoon, how likely are you to doze off? And how likely are you to fall asleep if you're sitting and talking to someone, or sitting quietly after lunch, when you haven't had any alcohol, of course? And how likely are you to fall asleep if you're in a car while stopped in traffic? So you don't have to share your scores, but it's useful for your own information. So you'd add up the numbers for your response from 0 to 3 for each of these. And if your score is 10 or less, that's pretty normal. If your score is 11 to 14, there's a mild chance you have sleep apnea, you're mildly sleepy. 14 to 17, moderate sleepiness, and 18 or higher, severe sleepiness. If your score was greater than 11, you should talk to your family physician. You could download an Epworth Sleepiness Scale from the internet and fill it out and show it to your doctor, but most of us actually have them in the office on our computers. So interstitial lung disease is scarring of the tissue of the lungs. And you can imagine if that tissue, that spongy tissue, is scarred, that it's not, the circulation will be impaired, the expansion, the drawing in of air, and the exhalation will be impaired as well, and your oxygen levels will be decreased. So the symptoms are generally shortness of breath, either at rest or with exertion or both. You might have a dry cough. It's usually diagnosed on a chest x-ray and then verified with CT scans. And it's a particular pattern when we do pulmonary function tests. This is a serious condition because the complications can include increased tension or hypertension in the circulation, like the pulmonary artery. It can lead to heart failure because that increased resistance in the blood flow passes back onto the right side of the heart. And it could exhaust the lungs and lead to respiratory failure because the chest muscles get exhausted. There are many causes of interstitial lung disease. So long-term exposure to hazardous materials such as asbestos, silica dust, grain dust, and some radiation treatments can cause damage to the lung tissue. And that's why we wear N95 type masks if you're someone that works in areas where you could be exposed to asbestos, because the fine fibers can really cause chronic inflammation when inhaled. And asbestos can also cause lung cancer in the long term, many, many decades after exposure. So there are autoimmune conditions. So autoimmune conditions is when the immune system is overactive in a particular way and causes inflammation. An example would be rheumatoid arthritis. Another autoimmune condition is sarcoidosis, scleroderma, and Sjogren's syndrome. These autoimmune conditions are sometimes associated with inflammation in the lungs that causes this interstitial lung disease. And there are even some medications that we prescribe that have an increased risk of being associated with interstitial lung disease, such as amiodarone, that's a drug used to control the heart rhythm, many of the drugs we use for cancer treatment, and some drugs that we even use for arthritis or inflammatory conditions, sulfasalazine. So if you have any of these exposures and you are feeling more short of breath or at increased risk, then talk to your doctor about considering x-rays or other investigations. Now, a pulmonary thromboembolism is a blood clot that blocks the flow of blood in an artery in the lung. So that's a serious life-threatening condition because that can cause further damage to the lungs, the death of lung tissue, and even death, depending where the blood clot is. And the usual source would be a blood clot in the vein. That's what we mean by a deep vein thrombosis. And of course, the symptoms of a blood clot in the veins of your leg would be swelling and pain, either in the calf or in the thigh, typically starting in the calf. So if you have these symptoms, don't wait a week or longer before you tell the doctor. Consider going to the emergency or try to get into an urgent care clinic or your family doctor. So this illustration tells you what happens with a pulmonary embolism. So it's a little blood clot that gets passed into a branch of the pulmonary circulation, into a branch of the pulmonary arteries. And then just like a heart attack, if the blood supply to the tissue is blocked, then the tissue downstream dies or is damaged. So the symptoms might include chest pain. Often there's a cough that may have blood in it as well. Often the heart rate is very fast, like well over 100 at best. You might have excessive sweating. You may be short of breath or lightheaded. And of course, if there's a clot in the leg pain and swelling. So we diagnose it with a CT angiogram. Often we do a screen with a blood test called a D-dimer. And if that's elevated, then we go on to a CT angiogram. And it's treated with anticoagulants, medications that thin the blood and dissolve the clot. And often that needs to be taken for at least 6 months after diagnosis. So pneumothorax is a rare but serious condition where the lung collapses. It's where air leaks out either into the space, the pleural space between the chest wall and the lung. So if air escapes from the lungs or comes from elsewhere outside of the body, like with a stab wound or stab injury or any blunt trauma to the chest or a broken rib that's displayed, it punctures the pleura, air escapes and fills the outside of the chest wall and pushes right onto the lung, and the lung collapses. So you would be acutely short of breath all of a sudden. And there's particular signs that we see when we examine the individual. So when we're percussing the chest, we're going to hear a lot of tympanic sounds, as if we're beating a hollow drum at the same time, rather than the normal dullness that we would feel over the chest. And we wouldn't hear air sounds on that one side of the chest. So examples could be after serious car accidents where there's trauma to the chest wall from a fall from a height. It could even occur with acupuncture if we're doing it. So you probably wouldn't do acupuncture in a thin person in the front of the ribs, because there's a high risk of puncturing the chest wall, puncturing the pleura, allowing air to leak out. And with certain medical procedures, we might accidentally, in the hospital medical procedures, we might accidentally puncture the lung and cause a pneumothorax as well. It's treated by actually putting another needle into the chest and attaching it to suction, and that's to remove the extra air. There's another condition called hemothorax, where due to an injury, there's blood that fills that pleural space outside of the lung, and it causes the lung to collapse. In that case, we also put in a big needle and drain off the blood and put it to suction and allow the lung to inflate again. So we covered all our material in good time. And just a reminder that I believe every one of you has a unique potential in this life. And it's our individual duty to realize that special potential, your gift to the world, and to help others achieve theirs. And I'm hoping with knowledge, engagement, and support, we can manage chronic health conditions like chronic lung disease and continue to live well. And a reminder, as I said in our last talk, that we all share the most common chronic condition. So everyone in this virtual room has the same chronic condition. It's incurable, it's sexually transmitted, and it has 100% mortality. And you probably guessed it, that chronic condition is life. So let's make the most of it. And together, let's share the information that you found useful to people you care about and your neighbors, and be part of our network of improving the health of everyone in our community, everyone we care about. And just a reminder, my next talk is What Do You Need to Know About Medical Ethics? And that's just a month from now, Thursday, April 13th. I was the chair of the Burnaby Hospital Ethical Resources Committee. So I actually I was like consultant for cases in the ICU and emergency, where people had to make decisions about discontinuing respirators, deciding on whether they wanted to be resuscitated or not resuscitated, deciding to start feeding tubes or deciding to withdraw feeding tubes. So I'd like to share the information of how you can make informed decisions, talk about advanced medical directives so you can make decisions ahead of time, talk about medical records, that's all your confidential medical information, who has access to that, and what you should know about your own medical records. And also the basic things that physicians should talk to you about so you can be informed and maintain your autonomy, ability to make your own decisions. So it'll be very practical, and I'll help you ask the right questions and get the right answers from healthcare providers at every level, from your family doctor to an emergency physician to any surgeons, to nurse practitioners, any other healthcare provider, so you know what questions to ask to be an informed individual and get the information you need to make the best decisions. And just a reminder, healthcare is self-care, and to pass that on to the people you care about. So thanks for your kind attention. And I'm
That's
hoping
great.
there's some questions.
There are. So I have put the link in the chat to register for the April 13th talk. So you can have it over and done with just like that. So questions. Teresa asked, how is mucus formed and how to get rid of it? I have lots in the morning.
Well, mucus is mucus is our friend. So it can be a nuisance, just like our emotions or troublesome thoughts. So just like a strong emotion like anxiety is actually a useful tool for survival, but it can get in the way if it bothers us or it seems to be excessive. So mucus is your friend too. So mucus is really important. There's little hair-like cells in your chest, in the lungs, the substance of the lungs called cilia, C-I-L-I-A, and they help move mucus and bring up mucus. So those cilia are helpful. So they're trapping germs and particles and dust that you inhale along with everything else, including the good air. And they help clear that and bring it up. And people with chronic lung disease, they sometimes produce a lot of mucus because of inflammation in the lungs. So one source could be from the lungs itself, and it could possibly be from chronic lung disease. So there are some people with chronic lung disease that are elderly that never smoked and didn't get secondhand smoke. Although it's hard to imagine if you survived the 1930s, 40s, and 50s and 60s without exposure to secondhand smoke, because people smoked everywhere until the early to mid 70s, as I recall. I used to hate bowling alleys when I was a kid because people were smoking there all the time. So mucus is the body's defense to collect material and to clear it. Sometimes it could be something really innocent. The most common would be if you had allergies, chronic allergic sinusitis. The sinuses are ear spaces within your bones that are connected to the nasal passages. So you actually have frontal, ethmoid, sphenoid, maxillary sinuses, and even sinuses behind your ears that have a mucous membrane. They do produce mucus as well. And if you have allergies, you chronically produce more of that mucus. And of course, you can imagine if your nose and your sinuses are producing mucus, it has to drip down somewhere and probably go into your throat. You either have to blow it out through your nose in the morning or cough it up in the morning. So depends on the cause of the mucus. So that's where all the mucus comes from. And I think some people are more phlegmatic than others, because I go to the swimming pool every day and there's some people that cannot resist spitting in the shower. I think some of them do swallow some water when they're swimming too. But and in the past, there used to be people that would be spitting on the pool deck, but the lifeguards are pretty good at picking that out and finding them out and arresting them and injecting them. So it could be something like allergies. And if you could see your doctor, and your doctor can see if you have signs of allergies and perhaps try antihistamines or nasal sprays that decrease inflammation in the nose and sinuses, that might improve it. But if it's coming from the lungs, then we want to check to make sure you don't have any chronic lung disease as a cause, like chronic bronchitis.
That's great. Thank you so much. Craig mentioned that Adrian Dix and Dr. Bonnie Henry are going to be speaking tomorrow at 1:30 to give an update on COVID booster doses. Do you have any thoughts or comments on what might be coming?
So thanks, Craig. That's Craig McCullough. He's a wonderful reporter. He keeps me informed of the next conference being held by Adrian Dix and Bonnie Henry. I think you should all listen in or actually get a summary from the update, because to find out what's available for COVID vaccines, because they're still out there and a lot of people are under vaccinated. So you do know the latest vaccines are updated to include Omicron variants, and that's been shown to reduce the risk beyond the basic individual shots you had at the very beginning. So they're new and improved, and they give you an extra level of protection. So even if you had COVID before, a combination of a past COVID infection and a recent vaccination in the past 6 months, so will give you some good protection, not 100%. And of course, being very cautious in shared indoor spaces. I still wear an N95 mask when I go shopping at Costco. I wear it all the time in the office, except when I go in the shower. I wear it to the community center when I work on the weights. I take it off briefly when I go swimming, because face masks don't work when they get wet. Don't try it out because you can't breathe. So I think we should find out what Adrian Dix and Bonnie Henry have to share with us tomorrow. Sure, I'll be listening in and at least getting a summary. I'll probably be talking to patients at the same time.
Oh, he said there's a live stream of the press conference. It will be on YouTube tomorrow, and he even shared the link. Craig, you're so good. Another question from Craig. How can different trauma affect your lungs?
I guess you're not talking about chest trauma, because of course blood trauma can cause a pneumothorax, a fractured rib. Most fractured ribs won't cause a pneumothorax. So if you break just one rib and it's a simple fracture, it's not displaced, that's only going to cause a little bit of pain. I see rib fractures all the time. And I do have sympathy for my patients, but in one incident, I had 9 rib fractures that involved 7 ribs, both sides of the chest. 2 of the ribs are front and back. So that was a lot of pain. So I tried to work really hard to empathize with the patient with just 1 fractured rib. Unfortunately, I didn't get a pneumothorax. That was from a special trick on the flying trapeze that I had on one vacation. But I survived, and I went back on the trapeze 2 days later and didn't tell them.
Oh, wow.
But I wonder if you meant like emotional trauma, how that affects the lungs. Is that what you meant, Craig?
I'm just gonna see. We can turn Craig. There you go, Craig.
Oh, was it Chris?
Oh, it was Chris Hoffman. I'm so sorry. Sorry, Chris. And it looks like we don't have Chris in. Oh, there it is. Sorry, Chris. You're live now.
Both emotional trauma and physical trauma.
Yeah, so physical trauma we kind of talked about, like broken ribs, pneumothorax, hemothorax can cause something really acute. Emotional trauma, not that we know of, that it will cause a physical effect on the lungs, but there'll be, depending on the trauma that you may have suffered in the past, sometimes we will feel short of breath. So when trauma is triggered, when we get things or situations or thoughts that trigger our past trauma, we remember it subconsciously, remember it in our body. A lot of our memories are stored in the emotions and the physical sensations at that time. So it can make us feel really, when we get triggered, then we can feel short of breath or suffocating, even though the structure of our lungs is actually fine. So it takes a specialized therapist, a trauma therapist, to work with an individual to uncover that and to, again, feel a sense of safety and to ground ourselves and know that we are now in a safe place and that you're safe from the trauma and emotional or physical abuse.
Thank you. Well, that's it. Does anybody else have any questions? We have a couple minutes if you want to pop them in the chat. Everybody's very quiet.
So yeah, that's pretty good. So first time with this new talk and I finished on time.
Exactly. Yeah. Okay, well, I think we did it with 12 minutes to spare. Oh, wait. Oh, somebody just said thank you. So lots of links in the chat. So hopefully some of those are helpful for you. Please register for April 13th, the medical ethics talk. We'd love to see you at Walk with Your Doc. So we have some fun stuff coming up as the weather's getting nicer. So hope we'll see you there.
Thank you. And thanks, Leona. And look forward to, if you could make it, if all of you out there would like to meet you in person, and you can ask me any questions. Share.
Exactly. And let's all pray for a nice day. We've been pretty lucky with Walk with Your Doc. So and like I said, just as I end the session, quick evaluation is going to pop up. So if you wouldn't mind filling that out, that's really helpful for us. And it gives you an opportunity to add your email to the email list that I use, and that'll give you reminders to all these upcoming events. Great from me.
Okay. Thank you, Leona.
Awesome. Thanks. You guys have a great night. Everyone. Have a great night. Thank you.
I'm about to sing happy birthday to my dad.
Say hi to happy birthday to your dad for me.
Thanks.
Bye.